The ankle, acute or traumatic injuries. The ankle is a stable hinge joint. Medial and lateral displacement of the ankle is prevented by both malleoli. The ligament arrangement limits inversion and eversion at the subtalar joint. The square shape of the talus adds to the stability of the ankle joint itself. The most stable position for the ankle occurs during dorsiflexion, and the least stable position is when the foot is in plantar flexion. The ankle itself plays a critical link in the kinetic chain. Injury prevention. General injury prevention to the ankle and lower leg includes ensuring patients are physically strong, have flexibility in appropriate regions, wear proper footwear for the demands of their specific activities, utilize protective taping, bracing, and orthotics, and engage in neuromuscular training. Neuromuscular and proprioception can improve the prevention of ankle and lower leg injuries. The assessment of ankle and lower leg injuries. The general assessment for the ankle and lower leg follows the same criteria and format of the foot. We first assess a patient's history, observe for any deformity or other signs, palpate the area, and use special tests to rule in and out specific conditions. All history questions are important, but an especially important question is any previous treatments. This is in regard to previous treatments that were used for specific conditions the patient is suffering from. We need to know what treatments were previously used and if they were effective or if they worked. If they did not work, why would we continue to include them? Inversion ankle sprain, also known as a lateral ankle sprain. An ankle sprain refers to tearing of the ligaments of the ankle and accounts for approximately 40% of all athletic injuries. 85% of ankle sprains occur on the outside or the lateral side of the ankle and are known as an inversion ankle sprain. This is the type of injury that most runners experience when they sprain their ankle. Medial ankle sprains along the inside of the ankle occur less frequently and are usually caused by fractures or other traumatic events. So why are inversion ankle sprains so common? You can chalk this up to our lopsided anatomy. The bone on the lower outside of the ankle, the lateral malleolus or the distal fibula, extends further down than the bone on the inside of the ankle, the medial malleolus or the fibula. This difference gives the inside of the ankle, the medial side, more stability than the outer side of the ankle, the lateral side. The ankle is commonly sprained when the foot is plantar flexed and inverted. Common signs and symptoms of an ankle sprain include lateral ankle pain, swelling, ecchymosis, and popping sensations. The patient may complain of an inability to bear weight or they may limp. Medial ankle pain may be present. This is typically from a compression of the deltoid ligament, as it can get pinched between the tarsal bones and the medial malleolus. At a symptomatic level, most ankle sprains appear to resolve completely without any rehabilitation or intervention. In reality, ankle sprains that have not been rehabilitated correctly are usually susceptible to further injury. Rehabilitation is very important to regain function and to strengthen the kinetic chain. Ankle sprains. The severity of ligament sprains is classified according to grades. In a grade 1 ligament sprain, the etiology, it occurs with inversion and plantar flexion and causes stretching on the anterior talofibular ligament. Signs and symptoms include mild pain and disability. Weight bearing is minimally impaired. The individual will commonly complain of point tenderness over the ligament, but there is no laxity of the ligament itself. The management is protection, optimal loading, ice, compression, and elevation. We sometimes use this acronym called POLICE that can be used for 1 to 2 days. We limit weight bearing initially and then aggressively rehabilitate the individual. Taping can provide some additional support, and the individual is typically allowed to return to activity in 7 to 10 days. In a grade 2 ligament sprain, the etiology is a moderate inversion force causing a great deal of disability. Most commonly, the anterior talofibular and calcaneofibular ligaments are ruptured or stretched. Signs and symptoms: the patient may have felt or heard a pop or snap. There is moderate pain with difficulty with bearing weight. Tenderness and edema is present. To manage a grade 2 ligament sprain, use Police at least for the first 72 hours. Use crutches for the first 5 to 10 days and progress to full weight bearing. This typically requires protective immobilization, but the patient should begin range of motion exercises early to aid in the maintenance of motion and proprioception. Taping can provide support during the early stages of walking and running. Long-term disability may include chronic instability with the possibility of injury reoccurrence, potentially leading to joint degeneration. The individual must continue to engage in rehabilitation to prevent against re-injury. In a grade 3 ligament sprain, the etiology is relatively uncommon, but can become extremely disabling. This is caused by a significant force, usually an inversion mechanism, resulting in spontaneous subluxation and reduction. This causes damage to the anterior and posterior talofibular and calcaneofibular ligaments, as well as the joint capsule. Signs and symptoms typically include severe pain, swelling, hemoarthrosis, and discoloration, and the patient is most likely unable to bear weight at all on this extremity. Grade 3 ligament sprain management includes Police. The physician may apply a dorsiflexion splint for 3 to 6 weeks. Crutches are provided after a cast is removed. Surgery may also be warranted to stabilize the ankle joint. An eversion ankle sprain, also known as a medial ankle sprain. An eversion ankle sprain is rare and occurs when the ankle rolls too far inwards. It is often accompanied by a fracture to the fibula. An eversion ankle sprain is a tear of the deltoid ligaments on the inside of the ankle. It is often called a medial ankle sprain or a deltoid ligament sprain. These ligaments provide support to prevent the ankle turning inwards or everting. Eversion sprains represent 5 to 10% of all ankle sprains. The deltoid ligament is far stronger and more stable than the ligaments of the lateral ankle. It is rare for the deltoid ligament to be sprained for 2 reasons. 1. The fibula bone tends to prevent the ankle from moving far enough to sprain or overstretch the ligaments on the inside of the ankle. It simply does not allow the foot to move far enough to cause damage. And second, the medial ligaments on the inside of the ankle are far stronger than the lateral ligaments on the outside of the ankle. For these reasons, an eversion sprain is often associated with a fracture of the end of the fibula bone, called a lateral malleolus, which can be felt as the bony part on the outside of the ankle. Other bones in the ankle, such as the talus, can also be fractured during an eversion ankle sprain. The patient will usually know that they have sprained their ankle. There will be immediate pain on the inside of the ankle after twisting it. There will be a rapid swelling and bruising may develop. They will typically have difficulty bearing weight and have limited range of motion. In moderate to severe eversion ankle sprains, it is always recommended that an X-ray is requested to rule out a possible fracture. A syndesmosis sprain, also known as a high ankle sprain. A syndesmosis sprain or high ankle sprain is a sprain of the syndesmotic ligament that connects the tibia and the fibula in the lower leg, thereby creating the mortise of the ankle joint. The talus fits inside a healthy mortise to support the body weight. High ankle sprains are described as high because they are located above the ankle joint itself. These types of injuries comprise approximately 15% of all ankle sprains. Unlike the common lateral ankle sprain, when ligaments around the ankle are injured through an inward twisting, a high ankle sprain can be caused when a lower leg and foot externally rotates or twists out. A high ankle sprain typically occurs when the foot is placed in external rotation and forced dorsiflexion. Signs and symptoms of a syndesmosis or high ankle sprain of the ankle are anterior distal tibia and fibular pain, swelling, but it is usually diffuse and is not as prominent as a lateral ankle sprain, and pain with all movements, but especially with weight-bearing activities. When weight is placed on the lower extremity, the talus pushes up between the mortise, separating the tibia and the fibula. As the tibia and the fibula are separated and torn apart, the syndesmosis continues to tear. You can see an example of this condition in the X-ray picture on the right. Management should include examining the lower extremity for fracture. It is not uncommon to have an eversion sprain with damage to the deltoid ligament at the same time as a syndesmosis sprain. Ankle sprain management. We typically follow a standard acute care process. We check for assessment for additional damage, use appropriate immobilization, and we can use what are called the Ottawa ankle rules. We'll talk about these next. Moderate to severe ankle injury should be referred to physicians for further evaluation. The Ottawa ankle rules. These are what are called clinical prediction rules. These are used for determining if someone needs radiographs or x-rays. An ankle radiograph or x-ray should be required if there is pain in the malleolar region with any of the following symptoms: bone tenderness at the posterior edge of the distal 6 centimeters or the tip of the lateral malleolus, bone tenderness at the posterior edge of the distal 6 centimeters or the tip of the medial malleolus, an inability to bear weight for at least 4 steps both immediately after injury and at the time of evaluation. A foot radiograph or x-ray series should be performed if there is pain in the midfoot region with any one of these following signs or symptoms: bone tenderness at the navicular bone tenderness at the base of the 5th metatarsal, or an inability to bear weight for at least 4 steps both immediately after the injury and at the time of the evaluation. Tibia, fibular, and ankle fractures. These 3 bones, the tibia, fibula, and the talus, make up the bony elements of the ankle joint. A fibrous membrane called the joint capsule, lined with a smoother layer called the synovium, encases the joint architecture. The joint capsule contains the synovial fluid produced by the synovium. The synovial fluid allows for smooth movement of the joint surfaces. The ankle joint is stabilized by several ligaments, which are fibers that hold these bones in place. When you stress an ankle joint beyond the strength of its elements, you injure the joint. If only the ligament gives way and tears, then you have sprained the ankle. If a bone gives way and breaks, then you have an ankle fracture. Fractures can occur simultaneously with tears of the ligaments, and we can do this in several ways. One, by rolling the ankle in or out, by twisting the ankle side to side, flexing or extending the ankle joint, or applying severe force to the joint by coming straight down on it, as in jumping from a high level. Common signs and symptoms include sharp, severe pain, immediate swelling, deformity, and crepitus. Ambulation is possible in cases of isolated fibular fracture. To manage a possible fracture, remove the shoe and the sock to expose the injury. Assess the neurovascular integrity. See if the patient can feel. In order to do this, we assess if the patient can feel normal sensation and has good blood flow to the extremity. In the cases of mild fractures, which typically include close fractures, meaning the fracture stays underneath the skin, a standard physician referral is warranted. However, some fractures are extremely serious. We need to assess the patient and treat the patient for shock. Activate emergency medical services and splint in the position you found them. The Ottawa ankle rules can help us with identifying fracture management. Osteochondritis dissecans, also known as OCD. Osteochondritis dissecans is a bone and cartilage condition that most often occurs in the knee. However, it can occur in the ankle as well. It has no known cause, but repetitive stress on a joint, low vitamin D levels, and a genetic predisposition are often linked to this condition. In the ankle, it typically occurs in the superior medial articular surface of the talar dome. Osteochondritis dissecans, or OCD, occurs when one or several fragments of cartilage with underlying subchondral bone partially or completely detach and move within the joint space. They are also referred to as joint mice. The mechanism is a single or repetitive trauma. Signs and symptoms include patients complaining of pain and effusion with signs of atrophy. Individuals may also report catching, locking, or feeling like the joint is giving way. To manage OCD in the ankle, an X-ray is required or an MRI. With incomplete or non-displaced injuries, immobilization may be utilized early, and if we delay weight bearing, sometimes this injury will heal itself. If the fragments become displaced, then surgery is necessary to remove the OCD from the joint space. Achilles tendon rupture. An Achilles tendon rupture is a complete or partial tear of the Achilles tendon from its insertion site on the calcaneus. This typically occurs with a sudden stop and go movement, or with forceful plantar flexion with the knee moving into full extension. This injury is commonly seen in males more frequently than females, and in patients older than 30, but can be observed in any age and is being observed in increasing numbers of adolescent patients. In general, most patients will have a history of chronic inflammation such as tendonitis or tenosynovitis of the Achilles tendon prior to the rupture. Hallmark signs and symptoms include a patient hearing or feeling a sudden snap. They may also feel like they were kicked in the back of the leg, followed by immediate pain, which rapidly subsides. There is typically point tenderness, obvious deformity, swelling, discoloration, a decrease in range of motion, and the patient will have a difficulty with walking and may experience what is called a drop foot. Achilles ruptures are usually managed with surgical intervention, resulting in a return to function of 75 to 80% of patients' previous capacity. A non-operative treatment consists of rice, NSAIDs, numbing agents, non-weight-bearing casts, followed by a walking cast for 2 weeks. Return to normal function can be up to 90%. The rehabilitation for this type of injury is typically long and will last the patient for approximately a minimum of 6 months. Fibularis or peroneal tendon subluxation and dislocation. This type of injury occurs in sports with dynamic forces being applied to the ankle. It may also be caused by a dramatic blow to the posterior lateral malleolus or by moderate or severe inversion ankle sprains resulting in tearing of the fibularis retinaculum. In some cases, tendon rupture may also occur. Signs and symptoms include the patient complaining of snapping in and out of the groove with activity. Eversion against manual resistance replicates the subluxation of the tendon. There is recurrent pain, snapping, and instability. Most patients will present with ecchymosis, edema, tenderness, and crepitus over the tendon. A conservative approach can be used to manage this condition. Breast ice compression and elevation, as well as NSAIDs and analgesics, can help with pain management. If a conservative plan fails, surgical intervention may be required. Shin contusions. These most commonly occur as a result of a direct blow to the lower leg. Signs and symptoms include intense pain and rapidly forming hematomas with a jelly-like consistency. The management for shin contusions include police, rice, NSAIDs, and analgesics as needed. We can maintain a compression for the developing hematoma, but know that the hematoma may need to be aspirated. This means that the hematoma needs to be drained. If a physician decides that a hematoma needs to be drained, this should be done in a medical office under sterile conditions only. We can help fit the individual with a donut pad and an orthoplast outer shell to help protect the area from further bruising. If this type of condition is not managed appropriately, it can develop into another condition called osteomyelitis. This is a deterioration of the bone. A muscle contusion. The contusions of the leg, particularly in the region of the gastrocnemius, are common. Signs and symptoms may include a bruise that develops, causing pain, weakness, and partial loss of the limb function. Palpation will reveal a hard, rigid, and inflexible area due to internal hemorrhaging and muscle guarding. The management for muscle contusion is most commonly to stretch to prevent spasm and applying a cold compression wrap and ice. If superficial and conservative therapy and massage does not return a patient to normal in 2 to 3 days, ultrasound may be utilized to help break up the area. To help break up the hematoma in the area, wrapping or tape can help to stabilize the area as well. Leg cramps and leg spasms. A leg cramp or a spasm is a sudden, violent, involuntary contraction, either colonic, meaning intermittent, or tonic, sustained in nature. The specific cause is difficult to determine, but these may be due to fatigue, loss of fluids, electrolyte imbalance, or inadequate reciprocal muscle coordination. Signs and symptoms typically include cramping with pain and contraction of the calf muscle. To manage, try to help the patient relax to relieve the cramp. Firmly grasp the cramping muscle, and with a gentle stretch can help relieve the acute spasm. Ice can also help to aid in reduction of the spasm. And if these become recurrent, it may be due to fatigue or a water electrolyte imbalance, so we may have to look at a patient's nutritional intake. A muscle strain. A gastroc muscle strain follows the same grading criteria as other muscle strains. This is typically the result of quick start, stopping, or jumping activity. Signs and symptoms include, depending upon the grade, there may be a variable amount of swelling, pain, and muscle disability. The individual may complain of feeling like their leg was hit with a stick. Edema, point tenderness, and functional loss of strength are also common. To manage muscle strains, we can use Price or Police, NSAIDs, and analgesics as needed. For a grade 1 calf strain, we should be given gentle stretching after cooling. Weight bearing should be as tolerated. We can use a heel wedge to reduce calf stretching while walking, and a gradual rehabilitation program should be instituted. Acute leg fractures. The etiology is commonly from a direct blow or indirect trauma. The fibula has the highest incidence of fracture, occurring primarily in the middle one-third of the bone. Tibial fractures occur predominantly in the lower one-third of the bone. Signs and symptoms typically include pain, swelling, and soft tissue insult. The leg will appear hard and swollen. The management includes reduction of the fracture site and casting for up to 6 weeks, depending upon the extent of injury. Surgical intervention, such as the image on the screen, with pins, plates, or screws, may also be required depending on the severity of the injury. Compartment syndrome is a painful condition that occurs when pressure within the muscles builds to a dangerous level. This pressure can decrease blood flow, which prevents nourishment and oxygen from reaching nerve and muscle cells. Compartment syndrome can either be acute or chronic. Acute compartment syndrome is a medical emergency. It is usually caused by a severe injury, and without treatment, it can lead to permanent muscle damage. Chronic compartment syndrome, also known as exertional compartment syndrome, is usually not a medical emergency and is caused by athletic exertion. Compartment syndrome develops when swelling or bleeding occurs within a compartment in the lower leg. Because the fascia does not stretch, this can increase the pressure on the capillaries, nerves, and muscles within that compartment. Blood flow to muscles and nerve cells are disrupted. Without a speedy supply of oxygen and nutrients, nerve and muscle cells begin to be damaged. In acute compartment syndrome, unless the pressure is relieved quickly, permanent disability and tissue death may result. This does not usually happen in chronic or exertional compartment syndrome. Compartment syndrome most often occurs in the anterior or front compartment of the lower leg or calf. Traumatic compartment syndrome. Acute compartment syndrome usually develops after a severe injury, such as a car accident or a broken bone. Rarely, it develops after a relatively minor injury. Conditions that bring upon acute compartment syndrome include a fracture, a badly bruised muscle, or re-established blood flow after blocked circulation, crushed injuries, anabolic steroid use, or constricted bandages. Signs and symptoms of traumatic or acute compartment syndrome include severe pain, swelling out of proportion, tight and shiny skin, numbness and tingling, and a diminished pulse. You should check the patient's distal pulse and activate emergency medical services immediately if there is no pulse found, as this is a medical emergency. Exertional compartment syndrome. The mechanism of injury is typically insidious and is considered an overuse injury. This is often seen in distance runners. 50 to 60% of individuals will have bilateral symptoms. This is chronic inflammation and metabolic waste builds up within the compartment of the lower leg. There is a fluid pressure increase that occurs with exercise. Signs and symptoms will include tight, cramp-like squeezing aching sensation, and sensation of fullness, weakness, or an inability to contract. These signs and symptoms typically subside or completely go away with rest, and neurological involvement is typically rare. Physical examination of acute and chronic compartment syndrome are necessary to determine the cause and treatment. For acute compartment syndrome, it is imperative that our patient goes to an emergency department immediately if there is a concern about acute compartment syndrome. This is a medical emergency. A doctor will measure the compartment pressure to determine whether an individual has acute compartment syndrome. For chronic or exertional compartment syndrome, to diagnose chronic compartment syndrome, a doctor must rule out other conditions that could also cause pain to the lower leg. For example, a doctor may press on your tendons to make sure that there is no tendinitis. They may order x-rays to make sure that the tibia does not have a stress fracture. To confirm chronic compartment syndrome, a doctor will typically measure the pressure in the compartment before and after exercises. If the pressure remains high after exercise, then an individual will be diagnosed with chronic compartment syndrome. To treat acute compartment syndrome, emergency surgery is required. There is no effective non-surgical treatment. A doctor will make an incision and cut the skin and the fascia covering the affected compartment. This procedure is called a fasciotomy. Sometimes the swelling can be severe enough that the skin incision cannot be closed immediately. The incision is surgically repaired when swelling subsides, and sometimes a skin graft is used to eventually close the area. Exertional compartment syndrome, on the other hand, can be treated conservatively with physical therapy, orthotics, and anti-inflammatory medications. If that does not work, then surgical intervention may be necessary.